Please start, sir.
Okay, let me share.
So just introduction, sir. Then I will hand over the forum to you. So good evening, all. In today's clinical conversation on prostate cancer, there will be two sessions today. First is with Dr. Amit Kumar, sir. It's our duty to introduce the speakers, although they do not need any introduction. But Dr. Amit Kumar, sir, is the SDA Director of Medical Oncology in Jayaprabha Medanta Super Specialty Hospital, Patna. And sir will be talking on reaching new heights in AMHSP care. Over to you, sir.
Thank you. Thank you for the introduction. So the topic assigned is about the reaching new heights in metastatic hormone-sensitive prostate cancer care. And these are the disclosure, being the slide being provided by the wearer. So if we start with the prostate cancer landscape, what we see that the initially it starts from localized or locally advanced prostate cancer.
Sorry, sir, but slides are not visible, sir.
Okay, just a minute.
Yes, sir, visible now.
Yes, not visible. Yeah, okay.
Yeah.
So the prostate, basically the prostate cancer landscape starts with the, initially we know it's the localized or the locally advanced prostate cancer. And thereafter there is a biochemical recurrence or what we say as a relapse. And then it may be a upfront metastatic hormone sensitive, newly diagnosed hormone sensitive prostate cancer. And there may be changed to a primary progressive metastatic hormone from the localized disease, or it may be a non-metastatic, also castrate-resistant prostate cancer, which may happen. And thereafter, all these leads to a metastatic castrate-resistant prostate cancer and finally terminal disease. So from this ASCO, basically this nomenclature is now also going to be changed. It's basically called as androgen pathway sensitive or androgen pathway resistant prostate cancer. Might be where the next time you may going to see. So there is a great opportunity to delay this metastatic castrate resistance prostate cancer, and there's a further to improve the outcome in the subset of the patients. Then initially the Stampede control arm, which has includes that shows the any newly diagnosed metastatic prostate cancer in the docetaxel era, that shows the failure-free survival and the overall survival has found to be improved with the ADT has found to improve, but now there is much better things to add to these. The initial is the addition of the localized therapy, that is the prostate radiotherapy for the metastatic HSPC. So it has been seen if there is a low volume disease that is less than 4 bone mets, in those subset of the patient, the failure-free survival has found to be improved with localized therapy like radiotherapy, or the overall survival is also found to be benefited. But if there is more than 4 bone mets, that is a high volume disease, in those subset of the patient, the difference between addition of prostate radiotherapy is not seen in either of the subset of the patient. So improving, if we have seen in the last decade or so, the initially docetaxel has been studied in the GETRIC or the CHARTED trial or the Stampede. Thereafter, the abiraterone being introduced in Stampede and Latitude, enzalutamide in ARCHES trial, and apalutamide in Titan. There is a further enzyme which shows enzalutamide, but the real change come from the PIECE-1 and the RSN, where the triplet therapy has come in picture. So we have now basically a large number of data supporting concomitant therapies. So what to choose in which patient, that is the important thing. So if we come initially to the CHARTED trial where the docetaxel is being used, it has shown it has been divided into a low volume or a high volume. And what we have seen that docetaxel plus ADT, the median OS in the high volume has increased from 34 months to 51.2 months with a hazard rate of 0.63, and which was found to be significant p-value. So there is an improvement in the overall survival of around 17 months in the high volume disease. But in the low volume, whether the docetaxel in addition to ADT has improved, so it is not like that. So in ADT alone, it is not reached, but with docetaxel and ADT, 63.5 months. So in the high volume, there is a definite benefit of adding docetaxel, but that hasn't been transformed in the low volume disease. Thereafter, the latitude, which has been shown abiraterone in the high risk, so now in metastatic HSPC, and here what we have seen, the at a median follow-up around 51 months, the median treatment exposure, something with ADT is around 14 months, with a combination of abiraterone 25 months. So there is a overall survival has increased from 36 months to 53 months. So it was the abiraterone was the first to show that hormonal treatment can be effective. However, it is very much important to understand the treatment journey also the control arm when interpreting this data. So what is the PSA progression and the other things you have to look in the data. So if we see the consideration for abiraterone used in the metastatic HSPC, even if only 5 milligram prednisolone has, so with abiraterone you have to add prednisolone 5 mg OD, as we know, in metastatic HSPC. The side effect profile, if we see the graded adverse event, the hypertension is around grade 3, 22% with ADT with abiraterone with prednisolone, as compared to 10% in the ADT with placebo arms. Hepatotoxicity is another, transaminitis is the thing which one have to be looking in. So it is something around 8%, hypokalemia 11%, cardiac dysarrhythmia, though we 3%, but it definitely happens if the patient is an elderly and there is a chance. So osteoporosis or a cataract or fluid retention are more or less similar in the both arms. So when abiraterone is being given, one has to look for these cardiac comorbidities, liver dysfunctions, and hypertension in the subset of the patient. Thereafter, the Titan trial, which shows the apalutamide in metastatic HSPC, it has shown so apalutamide plus ADT versus placebo plus ADT also. So the PFS in this shows the hazard rate of 0.548 and the overall survival 0.65. And if we go with the subgroup analysis, it has shown a benefit in both the low volume also and even in the high volume. So there is a PFS benefit with the addition of apalutamide. So apalutamide is now also in this ASCO has been promoted also in the neoadjuvant setting, where the combination has been used, followed by apalutamide plus ADT, followed by surgery in the subset of the patient, and has shown an improvement in the disease-free survival. So Enjamet in trial which shows enzalutamide in metastatic HSPC. So enzalutamide plus ADT versus only the non-steroidal agents with ADT. It has shown there is the hazard rate is of around 0.4 for the PFS, and for OS it is 0.67. And it has also shown that it's in the found to be somehow in the low volume it is found to be 0.43, for high volume it is 0.8. So the p-value for interaction 0.04. So somehow it is showing a much benefit in what we say the subgroup analysis. The OS is seen in the low volume. Now, going to the combination therapies to further improve these outcomes. So the PEACE-1 is study design, which is shown in a de novo cases with improved its both de novo metastatic recurrent or prior chemotherapy with a disease extent either a high or low volume and performance status 1 or less than 1. And these have been at least the patients include less than 3 months of ADT prior to randomization in the subset of the, and the stratification is based on the PS, metastatic site, type of castration, or whether the patient has received docetaxel or not. So initially, this trial has included only standard of care with therapy or the standard of care with radiotherapy, and the other group was abiraterone plus prednisolone. But it was further amended to include docetaxel during this trial, ADT plus docetaxel, and it has shown in the high volume disease, it has found to be the standard of care with abiraterone has shown a benefit. The hazard rate is of 0.72, but in the low volume, this benefit was not seen. So it clearly led to the confirmation that in high volume, one can improve further outcome by adding abiraterone to docetaxel versus docetaxel alone. In low volume, it doesn't seem to be as beneficial as the high volume disease. Harrison study, so that's the most important because we have seen the side effect profile of the abiraterone, which happens, and especially transaminitis and other, and one has to be very much cautious when using both docetaxel and abiraterone. So the other is this placebo-controlled phase 3, where the docetaxel 6 cycles along with darolutamide 600 mg/d in combination with ADT has been compared with ADT with docetaxel, and what we have seen, the stratification is based on the extent of disease, M1A versus M1B versus M1C. And the primary endpoint being taken as the OS in this trial, with the secondary with time to castrate-resistant prostate cancer or pain progression or the skeletal event-free survival to first symptomatic skeletal events and initiation of subsequent antineoplastic therapy, or the time to initiation of opioid use or the safety. So 87% received all 6 cycles of docetaxel. Adverse events between arms were almost identical, what we see. So the overall survival, it has been shown that it has been the median in the placebo is 49 months. With darolutamide, it has not reached. So it has increased from 50% to 63% in the subset of the patient. So, and this benefit is seen in all subgroups. So whether it's a high-risk patient or in the low risk, so we'll see the high-risk patient, the population, it is a 0.71, and the low risk, it is hazard rate is around 0.62. So the benefits of this combination therapy has seen in both the subgroup of the patient. So the Arasin key secondary efficacy endpoints includes the time to CRPC-VC. There is a 64% reduction in the time to castrate-resistant prostate cancer. The time to pain progression, there is a 21% risk of reduction. Time to first subsequent antineoplastic therapy, it has basically 61% risk reduction in the first starting of the other antineoplastic therapy. And in the time to first skeletal event, related event, it is 29% risk reduction is seen in this. Reduction has been seen in this subset. So Arasin, the PSA response and outcome is undetectable PSA, which we see the darolutamide plus ADT with docetaxel. So undetectable PSA level, what we see is has gone to 24 weeks. At 24 weeks, it has around 49% of the patient as compared to 24% in the ADT plus docetaxel arm. And at any time, so it has increased from 29% to 67%. So more than 2/3 of the patient reached below 0.2 in the overall study. So the time to PSA progression is also, one may say, has found to be significantly better in the case of the darolutamide with docetaxel arm. Overall survival, you may also see that is undetectable PSA at 36 weeks, detectable PSA further. So more than 2/3 of the patients reached below 0.2 in overall study. So the PSA response and outcomes in high volume metastatic HSPC, what we see is the undetectable PSA, that is, one may see the darolutamide triplet achieved a longer period of no disease progression and also significant improvement to overall survival. So the overall survival basically has had a hazard rate of 0.3. So it's one of the best hazard rate in any clinical trial. One may see that if you are using only docetaxel plus ADT, with the median is only 22.1 months as compared to darolutamide plus ADT plus docetaxel, where it has increased from 22.1 months to it was not evaluable in this subset. The PSA response and outcomes in the low volume HSPC has also shown to be the patient achieving undetectable PSA has increased from 39% to 83%. And time to PSA progression has shown a hazard rate of 0.09. So it has something 36% of the patient in the docetaxel has got this as compared to 91% of the patient in the time in the darolutamide arm. The OS is also has shown in the low volume has a hazard rate of 0.34. So what has to be important is deciding between doublet and triplet in metastatic HSPC. One has to consider about whether the patient is able to tolerate and accept docetaxel first. What is the extent of the disease, whether it's a high volume or a high risk or a low volume, low risk, likelihood of hormone insensitive clones, the age or the life expectancy of the patient. So when you want to hit hard and early, because prostate cancer will be the cause of the death, in that case you have to hit hard and early. If you see that the patient can live his life with the prostate cancer, then not. So will docetaxel be an obligation in the near future? One has to see, and much less effective therapies are there post ARPI progression. So that is one have to also remember. So, and the patient need to be informed and share decision with the patient to start any therapy. So with this, I like to end. So thank you. We'll open to questions. Yeah. So over to Arnav.
So I don't find any questions as of now, even not in the chat box. We moving forward to our next session is by Dr. Abhishek Anand sir, Director Medical Oncology, Narayana Cancer Center, and Paras HMRI partner. Over to you, sir.
रुक जाइए, अभी मीटिंग में है, बैठ कीजिए बाहर. Very good evening to all of you. Thank you, Bayer, for this opportunity. So I will be discussing about the advancing metastatic hormone-sensitive prostate cancer treatment horizons and what is the role of darolutamide without chemotherapy, and that is based on the aeronaut study, and what are the evidence we will just see. So these are the disclosures. The standard of care in metastatic HSPC has evolved to combine ADT with AR inhibitors like abiraterone or docetaxels. So, if you see the treatment timeline charted was the initial combination of docetaxel along with ADT, then Stampede, in which arm C will contain docetaxel along with ADT, then came the Latitude, that is again abiraterone with ADT, then Stampede arm G that contained abiraterone with ADT, then Arches that was of enzalutamide along with ADT, Titan study, Enzamet study, and Peace study. And despite the treatment with ARPI plus ADT or docetaxel plus ADT, a large proportion of patients with metastatic HSPC will eventually progress to metastatic CRPC within 3 years of the disease process. And Arasen study is of darolutamide along with ADT plus docetaxel, and then came the Aranod study, which was the darolutamide alone along with ADT, and then Arasic study, which was again darolutamide along with ADT. So there is unmet need in this prostate cancer basket. An unmet medical need remains for an efficacious treatment that offers a differentiated and improved safety profile for patients with metastatic HSP without adding significant toxicities and with a low drug-drug interaction potential. Arasen study, which is a phase 3 study in combination with docetaxel, already showed beneficial efficacy and safety profile of the metastatic HSPC patients, leading to its approval in India in 2023. Darolutamide in combination with ADT would provide efficacy benefit with favorable safety profile in metastatic HSPC patients, as demonstrated in the global phase 3 study, that is Aeronaut trial, with significant number of patients that was of Indian population. Patient with the aeronaut study, darolutamide has the potential to change the treatment paradigm, as now it would be only ARI which could be used with and without chemotherapy. A bit of background: darolutamide with ADT along with docetaxel has been the standard of care in metastatic HSPC. In the Arasen study, darolutamide, ADT, docetaxel demonstrated a favorable efficacy and safety versus ADT plus docetaxel in patients with metastatic HSPC patients. Aeronaut was designed to evaluate darolutamide plus ADT versus ADT to provide a new treatment option for metastatic HSPC patients without docetaxel. Another study design, so it is a randomized double-blind placebo-controlled phase 3 study. Patients with metastatic HSPC were enrolled. That was histologically or cytologically confirmed adenocarcinoma of the prostate with ECOG performance status of 0 to 2 and stratification factor being visceral metastasis, whether present or absent, or prior local therapy, whether given or not. Patients were randomized 2:1 to receive darolutamide with a standard dose of 600 mg twice daily along with ADT, and it was compared with the placebo along with ADT. Primary endpoint was radiological PFS, and the other pre-specified endpoint being the PFS2, time to skeletal related events, time to deterioration of fact, P total, time to first prostate cancer related invasion procedure. Coming to the demographic and clinical characteristics at baseline, it was more or less well balanced between the two arms, whether it is a darolutamide plus ADT or placebo plus ADT. And important thing is that Asian patients contributed almost 30% of all the trial patients in both darolutamide and the placebo arm. Country-wise representation was there, and from the Asian population was also there in the Aranaut trial, as you can see in the bottom left figure. Asian population, 30% of patients were of Asian descent in this trial. That is called the APAC regional representation, and in India it was 13.7% of patients and 14.3% of patients respectively in the darolutamide ADT and placebo ADT arm. Darolutamide plus ADT significantly reduced the risk of radiological progression or death by 46% as compared to placebo plus ADT. And you can see the hazard ratio for the radiological PFS, it was 0.54 with a significant p-value. So median after median follow-up, darolutamide group was 25.3 months, and in the placebo it was 25 months. The radiological PFS, the median was not reached in the darolutamide plus ADT arm, and in the placebo arm, it was 25 months. The benefit of darolutamide plus ADT on radiological PFS was consistent across all the subgroups, including the patient with high or low volume disease. Darolutamide plus ADT demonstrated a benefit across all the secondary endpoints, whether it is overall survival, time to metastatic CRPC, time to PSA progression, time to initiation of subsequent systemic therapy for prostate cancer, and time to pain progression. At the time of primary analysis, OS data were immature, and since the OS is immature, patient will be followed for survival. All the remaining per protocol placebo patients offered crossover to darolutamide after primary analysis. Darolutamide plus ADT delayed time to CRPC and time to pain progression, and time to metastatic CRPC. As you can see here, the median was not reached in the darolutamide arm, and in the placebo arm it was 13.8 months. Again, time to pain progression not reached in the darolutamide arm, and in the placebo arm it was 29.9 months. Delay in time to pain progression can be of high importance to the patient and have not been demonstrated with other AR inhibitors to date. Darolutamide plus ADT also achieved a deep and durable PSA response for patients having a PSA response of less than 0.2 nanogram per ml at any time duration. It was 62.6% from overall population in the darolutamide arm, and it was only 18.5% in the placebo arm. Time to PSA progression was also longer for the darolutamide arm. It was not reached the median time to PSA progression, and in the placebo arm it was 16.8 months only with a significant hazard ratio. A higher proportion of patients achieved unresectable PSA with darolutamide versus placebo in both the high volume and low volume subgroup, as you can see in the two graphs for high volume disease as well as low volume disease. The high proportion of patients achieved undetectable PSA. Subsequent life prolonging anti-cancer therapy, patients with subsequent life prolonging anti-cancer therapy was given to almost 32% of the patient in darolutamide arm and 42.5% of patients in the placebo arm. The incidences of treatment emergent adverse events were similar between the treatment groups, and discontinuations were lower in the darolutamide arm. The treatment emergent adverse events leading to permanent discontinuation of darolutamide was 6.1% only, and in the placebo it was 9%. So interestingly, it was higher in the placebo group as compared to the darolutamide arm. Median treatment duration was 24.2 months in the darolutamide arm versus 17.3 months in the placebo arm. The safety profile of darolutamide in the Aeronaut was independent of PSA response and consistent with the favorable tolerability first seen in the Aramis and the Aracene study. Rates of most common adverse events were low and similar between the treatment arms. As you can see in this table, fatigue was slightly higher frequency in the darolutamide arm as compared to the placebo. The rate of adverse events commonly associated with the ARPI were similar across the treatment arms. So darolutamide confirms a positive impact in the health-related quality of life as well, and it was presented in the ESCO 2025, where darolutamide extended a median time to deterioration in the FACT-P score by 5.1 months as compared to the placebo, and it is the only and the first AR inhibitor to demonstrate clinically meaningful delays in the pain progression as well as the overall well-being. The doublet therapy of darolutamide along with ADT demonstrates clinically meaningful delays in the deterioration of overall well-being, especially on the social, functional, and urinary symptoms domain. In conclusion, darolutamide plus ADT significantly improved the radiographic PFS in patients with metastatic HSPC. Darolutamide showed a benefit across all secondary endpoints. It was associated with a deep PSA response regardless of baseline PSA level. Darolutamide is the first and only AR inhibitor to demonstrate clinically meaningful delays in pain progression, overall well-being, including the social, family well-being, functional well-being, and urinary symptoms. And darolutamide had a favorable safety profile. Darolutamide plus ADT without docetaxel should become an additional standard of care for metastatic HSPC patients. So with this, I would like to conclude. Thank you so much. Thank you, Bayer Pharmaceuticals, for this opportunity.
Thank you, sir, for the nice presentation. And if anyone have any questions, you can ask directly. Sir, I don't think there are any questions as of now. Thank you so much for your nice presentation, sir.
Thank you so much.
And thank you, Amit sir, also, that is also present here. So I thank all the speakers and all the attending doctors for this evening's meeting. And with your permission, we can conclude the meeting, sir.
Thank you.
Thank you, sir. Thank you all. Tech team, we are good to close.